Okay, then, everybody, welcome. We are glad that you could make it to our COP. The title of this COP is MAT Practical Considerations, and this is being sponsored and facilitated by the New Hampshire Department of Health and Human Services, along with growth partners, the New Hampshire Technical Assistance Centre. So before I hand over to Elliot and our presenters, I'd just like to take care of a couple of points of housekeeping. So first of all, we are recording today's meeting, so we ask that everybody keep muted unless you're speaking. Later on, you'll have a chance to put your questions to our presenters, but until then, we ask you to stay on mute. If you're having any audio or video problems, you can reach out to me directly through the chat, and I'll do my very best to help you during today's session. So one thing we always encourage in our COPs is to have you engage. So feel free to use the emoticons in the reaction section of your toolbar. Also, you can write to us through the chat. And if you have any questions at any point, you can go ahead and type them in there, and we'll try and get to those questions at the end of the meeting. So with that, I'm going to go ahead and hand over to Elliot now.
Thanks, Stephen. Welcome, everybody, to our COP for today. You've done some of these before, I'm sure, so the format shouldn't be too unfamiliar. We're going to start off with presentations from Carol Furlong and Dr. Peter Mason, and then we're going to have some time after that for questions and answers from them. And I think we're going to ask for the Q&A part that people post things in chat. If you want to speak up, that's okay too. But actually, we probably won't be recording that part of the meeting. So yeah, that should eliminate that kind of concern if you were worried about that at all. So that's all we need to say about meeting format. I can probably move on. And the objectives for today. Presenters are going to discuss some myths and stigma surrounding MAT. Carol's going to talk about how to get people to the appropriate level of care on the ASAM levels of care. And then Dr. Mason's going to take a pretty deep dive into just a lot of the basics of how opioids work in the brain, OUD, and the medications that we're using to treat them. It's as far as why this is something we need to talk about now and why it's an important topic. It's hard to have looked at the news at all for the last few years and not seen that there's a real opioid epidemic and overdose problem in this country. So it seems like getting more effective treatments to more clinicians in more venues, available in more areas, in more ways, something certainly topical and something we should be addressing. And we're now going to do a little Slido survey for everybody. If you don't know, this is going to let us kind of take the temperature of folks on this topic of barriers to MAT. So you can scan that QR code up there with your phone. You can go to slido.com, enter that number you see on your screen. Or I think there's a direct link in the chat that Stephen's provided to Slido. So you can... that's a way for you to participate. Let's everyone take a minute, enter terms, words, thoughts you have when you contemplate the barriers to implementing MAT. And that should begin to populate itself with your thoughts. Give us a little more time to generate your answers. Yeah. You have another minute if you want, or a little more time anyway. But so far what we're seeing is 6 people have weighed in, and I think there's 6 different things that people are concerned about. Yeah, now stigma has taken a little more prominent position. That's interesting because I know I've heard Carol talk before about stigma in this respect, and she's going to talk about it again today. So that'll be, yeah, we're definitely going to have that on as one thing we're talking about. See, somebody's still typing, so we'll give that person a chance to weigh in, and then maybe we'll move on to our next slide. Okay, and public education. So the 7th term. Good. Okay. Well, that kind of frames things up nicely for us. I think all those areas are going to be dealt with by the presenters that follow. And speaking of those presenters, let me give you a brief introduction. So I'm going to introduce both of them up front. So when Carol's going to go first, and when she's done talking, Peter's going to pick right up and go from there. Carol's currently working at Elliott Hospital as an SUD strategic consultant. She's worked in the mental health and substance use environment for over 40 years. Carol began her career as a substance use counselor, working for the Department of the Army in Germany, continued her behavioral health career path when she returned to New England. She's developed and managed programs and provided care in all levels: inpatient, emergency department, PHP, IOP, outpatient. Carol strongly believes in integrated care and addressing all areas that impact an individual's recovery: housing, benefits, employment, family. Dr. Peter Mason has practiced family medicine for over 45 years and taught students at all levels of training. For 5 years, he was the medical director of the New Hampshire Region 1 Integrated Delivery Network, working to integrate behavioral health into primary care practices for the Medicaid population. He's been a provider of MAT since 2005 and is currently the medical director of Headrest Inc. in Lebanon, New Hampshire. Okay, Carol, take it away.
Thank you, Elliot. It's always interesting for me to reflect back on when I first started. I fell in love with the field quite by accident, by trying to become a mental health counselor working for the Department of the Army. And at the time, way too many years ago, the joke was there is no substance use in the military. And that was because if you were identified as having a substance use individual, you were no longer in the military. So my exposure to working in the substance use field was working on behalf of clients and with clients who had the entire system against them. It was a great introduction to the field. Go ahead and move on. So what is the problem? We know that in 2020, more than 41 million Americans were classified as needing treatment for substance use. That included 28 million with alcohol use disorder. We forget. We sometimes get so concentrated on fentanyl and methamphetamine use that we forget about alcohol and the problems it presents. 18 million with an illicit drug use disorder and 6.5 million with both. Go ahead. Over 97% of those 41 million don't believe that treatment is necessary. It's someone else, or it's not that bad. I just drink occasionally. It's hard for them to understand that people are concerned. And in 2020, just 2.7%, not even 3% of the people were receiving treatment of any kind. Those were great words that you all brought up, and I'm dying to find out more about them, because some of those are the reasons that these individuals are not receiving treatment. And then in March 2020, opioid overdoses jumped 18% compared to the same period the previous year. Well, we know what happened in March of 2020. Overdose deaths involving any drug use rose by 30% in the first year of the pandemic. People stayed by themselves and they used. What's the problem? Opioids began as an imperfect solution to pain management, followed by a period of practices of false marketing and overprescribing by physicians and pharmaceutical companies. We're beginning to see some of the consequences of that with the lawsuits about pharma, Purdue. But physicians were instructed and educated that these were non-addictive substances that would effectively deal with pain. And so they prescribed. When it became clearer that they were addictive, physicians very appropriately restricted their prescriptions. And painkillers were too expensive and too difficult to get. So heroin use and related deaths increased. And then the transition was made to a synthetic opioid, fentanyl, which is 50 times stronger than heroin. I talk to clients all the time who used to regularly use Percocets. But when Percocets became too expensive, they resorted to fentanyl, which is so much more powerful. From 2013 to 2019, the synthetic opioid-involved death rate jumped by more than 1,000%. Too many people are being lost. Go ahead, next. So is there hope? Recent studies have shown that 75% of people with a substance use disorder eventually enter recovery. How? Why? What is that magic turning point for them? You know the answer, but let's review. So what is addiction? I'm sure Peter's going to talk more about this. The emphasis is that it's a primary chronic disease, a medical condition of brain reward, motivation, memory, and related circuitry. Dysfunction in those circuits leads to characteristic biological, psychological, social, and spiritual manifestations. The individual either pursues reward or relief, a release from pain or a sense of reward and pleasure. Go ahead, next. It's characterized by an inability to consistently abstain, impairment in behavioral control, cravings, we talk a lot about that, diminished recognition of significant problems with one's behaviors and interpersonal relationships. They can't understand the impact of their disease, the impact it has on others. They don't even fully understand the impact it has on them. So it results in a dysfunctional emotional response. And of course, there's development of tolerance and withdrawal. Go ahead. How do we give them hope? How do we get them to maintain that hope in order to begin their recovery process? The first step in motivating people towards recovery is for you to believe in it. Whatever your position is, whatever field you are in, if you address people with a substance use disorder, you have to believe that this is possible. And you communicate that to them. Go ahead. So stigma, huge word on the words that we chose. And I've spent the last 5 years almost primarily just focusing on stigma as I address it in my institution and through education throughout the state. That's the beginning. It's not the end, it's the beginning of our efforts. We know that hopelessness keeps people from seeking recovery. If they don't believe they can recover, why would they begin? If they're hopeless, it's not going to work, why would I do it? Stigma reinforces that hopelessness. Think about the words we have used. We talk a lot about words matter, but even the words we use induce that hopelessness. You don't hear it as much anymore. Now you sometimes hear the word addicts, and we correct that. But in the old days, you used to hear junkies, and it wasn't done with a great tone of voice. We're labeling people and reinforcing that hopelessness. So the language and attitude we use is incredibly important. Attitudes influence how we act towards others. If I believe that their recovery is important, if I believe they have a medical illness, I'm going to treat them much differently. Go ahead. What is stigma? It's a mark of shame or discredit. You're not good enough. There's something wrong with you. It's an attribute, a behavior, or a condition that's socially discrediting. Go ahead. Illicit drug use is the most stigmatized health condition in the world, with alcohol use disorder not far behind at 4th in the world, among a list of 18 of the most stigmatized conditions internationally. Isn't that amazing? But studies have shown that portraying opioid use disorder as treatable can help reduce stigma associated with the condition. One of the manners in which I've been able to change or have a part in the change of my culture is consistently in reinforcing that this is a medical condition. I work in a medical environment. That's something people can understand. And once they begin to absorb that this is a medical condition, they treat it like all of the other medical conditions. It's treatable. It's resolvable. There's hope there. Go ahead. So what are some of the myths about addictions? You know these. You do a drug once and you're addicted. Well, I'm not proud to admit that when I was in high school, I wanted to smoke cigarettes. I thought it was cool. Tried it many times. Yeah, it never really took. So I'm not addicted to cigarettes. Trying once, experimentation does not automatically mean you are going to become addicted. Believing that is dangerous because people then say, you know, so-and-so tried fentanyl, he's not addicted to it. It can't be as bad as people think it is. So people who struggle with addiction use substances to curb pain. It's not just because of the physical aspect of it. Go ahead. We just need to get all the drug users out of the community to end the drug problem. Wouldn't it be interesting if we removed everybody that had a drug issue from a community? Who would be left? The perception, the stigma is that you remove homeless individuals, perhaps, and the drug problem would be gone. But what about the teachers? What about the professionals? What about the medical providers? What about the counselors? What about the business leaders who have drug problems? We wouldn't have much of a community left. It's better to just try to resolve this, try to treat it. The fact is that ostracizing people who use drugs simply push the substance use underground. We become more careful about it. We become more secretive about it. And where is the major source of available drugs? Primary care providers, medical providers, medicine cabinets. I remember going to a training years ago and they said, do you know when you are selling your house and people come for an open house, sometimes the first place they go is to use the bathroom because they can look in the medicine cabinet and get the pills that are there. There are many more sources than we're aware of. Go ahead. You have to hit rock bottom before we can help you. That's the old way of thinking. When I first started, people went into residential treatment and the treatment philosophy was to break them down to the very basic elements and then start to restore their confidence and their beliefs in themselves. Hitting rock bottom can be more destructive than ever because of that increased hopelessness again and helplessness. That's not helpful. Go ahead. If you really loved me, you'd stop using. As if it's a choice, as if it's not a pain relief, as if it may not be perceived as the only source of pleasure. It's not about choosing you because I don't love you. It's about choosing the one thing I believe is necessary for my life. Go ahead. If someone just uses willpower, they should be able to stop. The problem is, again, this is not a moral choice. This is a medical condition impacted by changes in the brain that impact on a person's self-control and ability to make good decisions. Go ahead. Addiction mostly affects certain types of people. Again, isn't that stigmatizing? We forget that people from all walks of life have addictions. This is not a disease that discriminates. Go ahead. People can't be forced into treatment. If treatment is forced, it will fail. The reality is that's not true at all. Those who are pressured into treatment are just as likely to benefit as those who enter treatment voluntarily. I work with a drug court program, and that's a classic example of this. These are people who, on the surface, choose to come into treatment, but most of them will admit that in the beginning, it was a way to stay out of jail. They didn't really have any intention of treatment, pursuing treatment. But we open the doors for them. We give them hope. We give them steps to take to see success. That's what it's about. Go ahead. Harm reduction enables substance use. So Peter's going to talk about MAT, and what we hear frequently is, yes, Suboxone's just another drug. You're just continuing the cycle. The reality is harm reduction in whatever form saves lives and provides safe options to people struggling with addiction. If we can keep them alive, we can continue to pursue treatment with them. Go ahead. How do you find quality treatment? And how do you determine the level of care? So first, what is quality treatment? Go ahead. 5 signs of quality treatment. There's licensed, certified, staff are qualified and receive training. Medication is offered. The agency offers FDA-approved medication for recovery from alcohol and opioid use disorders. And if it's a co-occurring program, they also are evaluating depression, anxiety, and treating those appropriately. They use evidence-based practices. We offer treatments that are proven to be effective, not something that we're just making up on a spur of a moment. Families are included. Families have to be included in this treatment process, because once that individual leaves treatment, they are going back into that environment where they are going to have the same stressors, the same pressures. Families need to understand their recovery, not only the individual's recovery, but the family's recovery process and supports. The agency provides ongoing treatment and supports beyond the substance use issues. Go ahead. What are some of the questions we ask? These are the levels of care: early intervention, outpatient services, intensive outpatient, partial hospital, residential inpatient, and medically managed intensive inpatient services. The questions we ask are about withdrawal. Have they been through withdrawal? Has it been a problem? Because that's going to indicate either a medical stay or a higher level of care. Do they have any skills? Have they been in treatment before? Do they have any skills that we can build on for them? What's their support network? Are there people, is their housing safe? Are they living with people who are using or who will not support them? Those are all critical questions that we ask to determine the levels of care. Go ahead. So level 0.5, early intervention services. We provide education, resources, and counseling to individuals at risk for substance use, but who don't meet the diagnostic criteria. So a person may be misusing alcohol and drugs, but hasn't developed an addiction. We're trying to catch this as soon as possible. So those high school students or college students who are misusing, binge drinking, haven't had serious consequences yet, but maybe need to be aware of those potential consequences. Early intervention. Go ahead. Outpatient services. So fewer than 9 hours of service a week is classified as an outpatient service. It's administered by addiction professionals or trained clinicians. We evaluate, we provide treatment, and we offer recovery follow-up services. There's usually medication involved. It's group or individual abstinence counseling, relapse prevention, and drug and alcohol education. Go ahead. The next level is IOP, intensive outpatient services. This is 9 hours or more a week, and it's usually for 90 days. So it's spread out. It's not obviously a portion of every day, but for example, it might be 3 days a week of 3-hour intervals. And again, we provide group and individual counseling, relapse prevention, drug and alcohol education. It provides more SUD counseling, so now it's 9 hours more, and it's designed to meet the multidimensional needs of people with addiction and comorbid conditions. Particularly have to pay attention to co-occurring mental health and substance use. I just don't see that many substance use clients who don't have a co-occurring mental health diagnosis. But in many levels of care, in many treatment facilities, that is never addressed. Remember, if we're using substances to relieve pain, and depression is that source of pain, we need to address that too. Go ahead. And then partial hospitalization program. Partial is 20 hours or more of service a week. It doesn't require 24-hour care. And I almost hate the name of this, partial hospitalization, because people think it has to be in a hospital. It is not. Partial hospitalization is frequently an outpatient service away from the hospital. It's for individuals living with unstable psychiatric and SUD conditions. It's delivered by an interdisciplinary team of providers. And again, it includes individual and group, educational groups, motivational enhancement and engagement strategies, family therapy, and other skilled treatment. And it usually includes case management to provide some aftercare for these individuals, while additionally exploring their social determinants of care. Okay. And then we have residential and inpatient services, typically provide 24-hour living support and structure with support from trained SUD treatment, mental health, and general medical personnel. The low intensity residential services include at least 5 hours of clinical service. So I want to make that point because people don't understand that residential inpatient services are not more intensive clinical services than some of the lower levels of care. The difference is you have that residential component, and we'll talk a little bit more about that. Services include medication management, recovery skills, relapse prevention, individual treatment, family therapy, case management. It includes credentialed medical, addiction, and mental health professionals providing these services. It should be looking at the whole person, as is true of some of the other lower levels. Okay. And then medically monitored high intensity inpatient services. This is withdrawal management. So it's 24-hour nursing care in an inpatient setting with an available physician. They require medication and have had recent experience with not being able to complete a withdrawal management program. So this is a more intense withdrawal. That's why some of the questions we ask when we're doing our assessment is prior withdrawal. Because if they've had, for example, serious, significant withdrawal from alcohol, we have to be very cautious about that. Okay. And then level 4, medically managed intensive inpatient services, 24-hour nursing care, daily physician care for severe unstable problems. This is commonly known as detox. It's generally provided in an acute care general hospital, an acute psychiatric hospital, or a psychiatric unit within an acute care general hospital. The length of stay is sufficient only to stabilize the acute symptoms of withdrawal. So primary focus is care management, case management, and care coordination. That's one of the misunderstandings about detox. People send individuals in for detox and think they're going to be there for a long period of time. It's just to clear the acute symptoms of the medical withdrawal. That's it. And not everybody needs a medical detox. If people think that medical detox is going to be the entry point of recovery, many times they are sadly mistaken. Unfortunately, people will go into detox because they don't want to withdraw on their own at home. It's uncomfortable. But then they start to use again because they're not in treatment. Okay. Which level of care is the most appropriate? You assess all of those matters. And the answer is the level that meets the needs of the client and provides all of the criteria of quality, effective treatment. Go ahead. So as always, least restrictive care first. And then, to me, the most important question is, which level of care meets the client's or the patient's needs, not the needs of others? It's not put him in the hospital, I need to be away from him. Or put him in a residential program because he needs to be away from us. Residential programs are incredibly important if they are living in a home or an environment where there are many drugs available, and it would be difficult, if not impossible, for them to start their sobriety. But what you have to keep in mind is, once they leave that residential program, they're going to go back to that same environment. So we have to make sure that those programs, wherever they are assisting them in addressing how are they going to handle those same stressors when they go back. Okay. So we still want to be hopeful. When we utilize our resources, all of our resources, we provide positive reinforcement, and we help people with kindness and respect. We help them acknowledge that this is a medical illness, not bad or immoral choices. We increase their chances of getting well because we're building that hope. We're destigmatizing. Go ahead. They may not seem like they're hearing you or responding. They may seem like they're shrugging off whatever recommendations you make, but they carry your words and their attitude and your attitude with them when they leave. Time and time again, we hear people in treatment say, I remember this one person, I wasn't ready for treatment, but they treated me like a person and they gave me some ideas and they believed in me. And I've carried that belief with me. It's incredibly important that we give them those gifts. Okay. That's it.
I always like listening to Carol. She's so clear. She's had so much experience. I'm going to share my screen here. So I'm going to cover a lot of ground here, and I'm going to go fairly quickly. My slides are going to be available to you, so don't feel like you have to get it all on the first take here, and I'm happy to answer questions about it afterwards as well. So I have no disclosures, and I'm going to be talking about medication-assisted treatment, and Carol talked about how important language is. Well, language is evolving. We've always talked in the past about medication-assisted treatment, but now people are talking more about medication for addiction treatment, or the most commonly used term is MOUD, medication for opiate use disorder. And the reason for that is not to disparage any of the other kinds of therapy that goes on for substance use disorders, but it's very clear that the evidence-based treatment that really clearly works is that uses medication. And instead of medication assisting the other treatment, now it's the primary treatment is using the medication to stabilize people and using behavioral therapy to help people with their full recovery. There are a number of medications that are used for this, and important concept is that there are receptors in the brain and other parts of the body that the opioids, which I'm going to be focusing on, the opioids stimulate. And this just shows parts of the body where they're involved. The one on the far left, the pink one, is the mu opioid receptor. There are other opioid receptors as well, but you'll hear, if you look at the literature, people are usually talking about mu receptors. What's the concept of receptor? Well, what happens is you've got this receptor, and let's particularly talk about the receptor in the brain, and the substance that stimulates that receptor is pictured in green here, and let's talk about any of the full opioid agonists. There are full and partial agonists. The full opioid agonists, like heroin, fentanyl, that stimulate these receptors have a full effect because they perfectly fit into that receptor. And when they do that and they stimulate it, you get euphoria, you get that full opioid effect. And if somebody was going through withdrawal and they get a full agonist, whatever that agonist is, that's a full agonist, all of a sudden that withdrawal, those withdrawal symptoms disappear. The other kind of agonist is a partial agonist, and that's illustrated on the right by those little yellow dots. So they stimulate the receptor as well, but it's an imperfect fit. So you don't get that full opioid effect. You don't get the euphoria. But the partial agonist can still eliminate those withdrawal symptoms. And while those partial agonists are on there, you can see that they're blocking the full agonists from getting on there. So that's an important concept I want you to keep in mind as we talk about the different kinds of medications that are used. And this is a good illustration of what's going on with acute and chronic use of opioids. So in the white is the normal range. And what you're seeing here with the blue line going up and down is that represents people taking some kind of an opioid. So let's say somebody's using heroin. They start off feeling normal. They take the heroin and they become euphoric. Then the effects of the heroin wear off. They're back to feeling normal. They take it again and they feel euphoric. And then they go back to normal. That's when people are using it acutely and they don't have any physical dependence or tolerance of it. But over time, with chronic use, they do become tolerant. And so using the opioid doesn't cause that euphoria any longer. And the reason that people are taking the medication, using that substance, is to prevent the kind of nasty withdrawal symptoms that they get that are the result of their tolerance and physical dependence. And to the far right is OAT, opioid agonist therapy, which we're talking about here. And that's where people are using and a medication for opioid use disorder that normalizes the situation. When you use these medications, you don't become euphoric, and you don't have the withdrawal symptoms. So there are 3 different medications that are used for opiate use disorder. There's methadone, buprenorphine, and naltrexone. I'm not going to spend a lot of time on naltrexone nor on methadone. I'm going to pretty much focus on buprenorphine. But it's important to mention them because they all could be part of a program. And Carol talked about individualizing recovery programs. So methadone's been around since 1972. It is a full opioid agonist. It has the same kind of effect on the receptors that fentanyl and heroin have, and it's taken orally, either as a tablet or a liquid. It can only be dispensed at a certified opioid treatment program, and there aren't very many of them around. There's a lot of really good evidence that actually the best results as far as keeping people keeping people in recovery is with methadone, but there are some problems with methadone programs. There are some problems with having people on methadone, and maybe in question and answer we can get into that. I'm not a huge methadone fan, but it is very effective when it's used as part of a really good program. Buprenorphine is what we're going to be focusing mostly on. What you see up above in the bold letters are the different brand names for buprenorphine. Naloxone, which is Suboxone, is the term that people use a lot for the combination of buprenorphine and naloxone. That was the first one out of the gate, and now most people are getting it in a generic form. You can use it as a sublingual tablet or a sublingual film. This slide is a little bit out of date because there used to be a buccal film that was Bunavil. It isn't on the market any longer. It can be implanted, or it can be the little capsule implant like they do with some of the birth control medications. so that lasts for a long time, or you can get an injection that lasts for 28 to 30 days. That's Sublocade. Until very recently, you had to go through a special program, 8 hours of education to get a waiver to be able to prescribe buprenorphine. As most of you know, within the past month, that was in December, that requirement was dropped because the epidemic is so serious that it was felt that we need to make it much more available to people. There was an interesting article in the New York Times a couple of days ago. It was an op-ed talking about the fact that in France they got rid of any special requirements. Anybody could, any licensed prescriber could be prescribing buprenorphine, and they had a dramatic drop in their death rate. So now we've done the same thing. Let's hope we have the same kind of result. There are over 1 million patients right now receiving buprenorphine from retail pharmacies. Buprenorphine, naloxone, the combination, the Suboxone combination, combines buprenorphine with naloxone, and you know naloxone as Narcan, brand name Narcan. What that does is it prevents people from misusing the buprenorphine, because if you had just buprenorphine alone, it can be injected. People can take the pills or the films, they can melt them down, they can inject them, and they could get high, because even though buprenorphine is a partial agonist, it's not a full agonist, a partial agonist, it still will produce some of a high if it's injected. And so the naloxone is combined with it, and if people tried to inject melted down Suboxone, they would get no effect whatsoever. In fact, with the naloxone in there, if they had some more opioid on board, they would actually go into some withdrawal. The naloxone does not have any effect when it's used orally, sublingually. It gets destroyed by the stomach acid. So it's only to prevent misuse from injection. Naltrexone was originally developed to help people with alcohol use disorder. If they were using it, they did not, if they use it, they don't get high from the alcohol, but it's been found to be very effective for opiate use disorder, and most of the time it's used in an injectable form called Vivitrol. And people who have that injection, they can have it once a month, and during that month period of time, if they try to use an opioid, they just don't get any kind of euphoric effect from it. And there are some people who feel that it also has some sort of a deterrent effect, that they don't have, the cravings are not as great with it. It's hard to know whether or not that's psychological, whether that's actually, a placebo effect, but at any rate, it is effective only if somebody shows up on time to get their injection on a regular basis. That's one of the reasons why, even though it's effective orally, most clinicians do not prescribe it orally, because people have to take it. They just have to, if they stop it, they can go ahead and misuse. So what are the outcomes from MAT? And I'll use the term MAT because it's convenient, or MAT or MOUD. First of all, you get a reduced risk of HIV and hepatitis C, these really nasty infections. And there's a decreased risk of opioid overdose. There's a significant reduction in suicide. There's lower utilization of non-opioid medical services like the emergency room and hospital admissions. People who are on MAT are 60% of them are abstinent after 1 year with the medication. I'll show you another slide on that. And 50 to 60% remain in treatment after 1 year. Those are pretty significant statistics. If you don't have MAT and you only use behavioral interventions, then more than 80% of people will return to using substances. There are very poor results, as Carol mentioned, with detox. It is not treatment, and it's kind of a revolving door. It's amazing how many people I've seen who I've treated with MAT who say that they have detoxed 8, 10, 12 times, and it's not treatment. So let's look at the death rates. The green is the general population, and use that as a baseline. And if you look at people who have not had any treatment, they have 6 times the death rates than the general population. If they go through detox, it's still almost 2.5 times the death rate of the general population. But if people get MOUD, there's a very significant decrease in those death rates. That's what we're aiming at. This is a slide that goes back to 2009. It was a study that was done in Baltimore, but it's true today. The red line just shows the decrease in heroin overdoses at the time. That was before the fentanyl epidemic, but that was a heroin overdoses. The dotted line on the top is methadone patients, and the one at the bottom, which is rising rapidly from the year 2002, is the use of buprenorphine. That's when that Suboxone was first introduced. And you can see with the combination of the two, both methadone and buprenorphine use, not used together, but their prevalence in the treatment community, the death or the overdose rates, fatal overdose rates decreased by 50%. And that's pretty dramatic. So again, to just repeat, psychological counseling plus buprenorphine results in 50 to 60% of patients still in treatment after a year, and reduced infections and fewer emergency room and hospital admissions. I want to mention something about the people being in treatment after a year. Carol did a really nice job of talking about the fact that what we're talking about with substance use disorders, that these are not moral failings, they are chronic diseases. And a lot of physicians don't recognize the fact that when you have 50 to 60% of patients still in treatment after a year, that really, that means 40 to 50% are not in treatment or not doing what they need to do to take care of the substance use disorder. That compares very favorably with people who are taking medication for hypertension or for diabetes. This is a treatable disease like other treatable chronic illnesses that primary care people see. And this chart on the right, the heavy squares show what happens, people who are retained in treatment, who have had no medication but just counseling, and that's at about 60 days. That's the control group. But those who have been on buprenorphine as well, they have that 50 to 60% retention rate at a year. So let's talk more about buprenorphine. Recently, with the relaxation of the requirements for people to have 8 hours of treatment, 8 hours of education to get waived to be able to prescribe Suboxone, buprenorphine, people started to say, well, people are going to indiscriminately prescribe it, and there's going to be a lot out on the street, and there are going to be a lot more deaths related to it because people are going to be misusing buprenorphine. They're going to be doing the things that I was talking about before. And in fact, that's not the case. In fact, what was shown, recent study that I found in the Journal of American Medical Association, was buprenorphine was involved in only 2.6% of opioid-involved overdose deaths, buprenorphine being considered an opioid as well, and in only 2.2% of other drug overdose deaths. So there's not a real difference between other substance use deaths and opioid deaths with buprenorphine being involved. So we don't really worry about buprenorphine being a problem there. So let's get to the meat of what the nuts and bolts of what we wanted to talk about. Let's look at the barriers to prescribing MAT, and I'll talk a little bit about a program that I had started when I was in primary care practice to initiate treatment with buprenorphine, and also how do we overcome some of the barriers. So there was a study done, a rural survey of physicians, and why weren't they why weren't they prescribing this medication, which is effective? Well, they were concerned about diversion 48% of the time. They said they don't have the time to do it. There are not available mental health or psychosocial support services, and that's still significantly true. Those of you who are on this call know that. We just don't have enough backup. Lack of specialty providers for backup if there's you have some issues and you need some consultation. Who do you call? They don't know who to call. A lot of people were concerned of maybe attracting drug users to their practices. Well, that's just that's ludicrous, because we all have had people who are using drugs, misusing drugs in our practice. They're there, and so often people don't screen for it. They don't ask the questions, so they don't think they've got them. And then there were concerns about DEA, Drug Enforcement Agency intrusions. In all the years that I have been prescribing, I've only been visited once by the DEA. They wanted to make sure that I was doing good record keeping, that I was using evidence-based treatment. What are the other barriers? Well, insufficient nursing and staff support. Carol talked about the fact that this is a team sport, and if you don't have nursing and staff support, you get some real problems there. And in primary care, particularly, in hospitals as well, we just don't have the personnel. There's such a dearth of nurses and MAs and front desk people, etc. There's a barrier of insufficient staff knowledge. Stigma. We keep talking about it, and those attitudes are important, because people would show up at an office and say that they were there to get buprenorphine, or supposed to see the doctor to help with their substance use disorder, and get treated like dirt at the front desk. So, or the people who brought them back into the room didn't treat them with the kind of respect and dignity that they deserve. So that's a problem. Insufficient clinician knowledge, and that is still a barrier, even though people are now able to, anybody with a license, a physician assistant, a nurse practitioner, an MD, a DO, can all prescribe buprenorphine, but if they don't have sufficient knowledge, that's really an issue for really successful programs. Then there's insufficient institutional support. Many of the practices today are run by hospitals. The majority of primary care practices are part of hospital networks, and with some ignorance and stigma on the part of hospital administrators, there's not institutional support for doing the things you need to do, like hiring behavioral health people to be part of a team. There are payment issues. There are a lot of the people who are misusing drugs don't have jobs. Their lives are in the toilet, and they're not able to access care because of that. And then there's what Carol mentioned, concern about substituting one addictive drug for another. Well, that's another myth, because what you're doing is you're substituting a drug that has positive effects for one that has extremely negative effects. How do we overcome these barriers? Well, first of all, I too have spent a lot of my time around the state talking about stigma, how to recognize it and how to reduce it. We've talked about educating all the staff team members that addiction is a chronic disease, not a moral failing. Engaging learners early is very important. I spent a lot of time with medical students, exposing them to people who have substance use disorders, and that's happening with PA students, nursing students, etc. And it's not so much a problem with these young clinicians. The problem is with people my age, my cohort, who are carrying along these stigmatizing attitudes that really go back to what they learned from their mentors. So we have to provide expert mentorship opportunities. There are a number of different models that get past some of the barriers, like the time barriers. In Massachusetts, they've had a very effective nurse care management model where they have dozens and dozens of people in a single program managed by a nurse who coordinates it, and the prescribing is done by clinicians who have the license to prescribe, but the the program is managed by a nurse so that the time constraints are mitigated. We have to develop a workforce. We need more licensed alcohol and drug counselors. We need more behavioral health people. We need more primary care people. We need to develop a behavioral health treatment network. We don't have enough people to deal with those co-occurring conditions as well. And we need to engage the senior leadership and management of those institutions so they understand the needs. There are people who have talked about the equity issues involved here. There are studies that show that even in communities that have the availability of treatment for substance use disorders, that American Indians, Alaskan Natives, Blacks, and Hispanics have higher death rates, higher overdose death rates than white non-Hispanics in those communities. And it's, even though the care is available, but it's probably reflecting lower access for those populations. And some of those barriers are, they mistrust the healthcare system, they've been stigmatized, they don't have transportation, or they don't have insurance. So the program that I started in my practice way back in 2005, which was very satisfying to me because I saw so many people get their lives back together and get jobs, become productive members of society, feel good about themselves again. That program, the components of it included an agreement, a written agreement between myself and the patient. And I got to tell you, when I started this program, I was a real hard ass. One of the things that I used to say that was part of the agreement was if they used any other substance, they were kicked out of the program. And I would say, 80-90% of people who are misusing opioids also are smoking marijuana. And so if we did drug screens and people had marijuana show up, we said, well, you're out of the program. Well, that is a death warrant today. Back in 2005, fentanyl wasn't on the scene, and it wasn't as much of a problem. Today, I think when we talk about harm reduction and we have these kinds of agreements, people understand that when somebody has a slip or a relapse, whatever term you want to use, and they have a drug screen that shows that they've been using again, you don't rip them apart for it. You say, you wrap your arms around them and say, what happened? Let me help you. Let's figure out a way to get you back on track and get you back into recovery. In fact, one of the things that I've learned, so many of the folks that I take care of have trauma histories. I have learned that instead of saying, what's the matter with you to somebody, I say, what happened to you? What happened to you? And that's on so many different levels, because if you listen to people and understand what happened to them, you're provided with a lot more ability to help them and get them into recovery. So other parts of this program I had involved regularly scheduled appointments, counseling. Everybody had to have counseling with a licensed alcohol and drug counselor, and many of them, because of the co-occurring conditions, were referred as well to some other behavioral health person who could help them with their post-traumatic stress disorder, their depression, their anxiety, whatever. Each patient was established with a PCP. It was either myself or one of my colleagues, because there was so much carryover with other healthcare, chronic health needs. The agreement that we had said that the individual would allow me to communicate confidentially with the LADAC or behavioral health people who were taking care of them as well. And there were regular drug screens, including random ones. Key components involved the necessity to keep appointments with the counselor and myself. All prescriptions were filled at a single pharmacy, so we were able to track that. Patients consented to communication between providers, as I mentioned. Patients will not behave inappropriately with staff, and that was a problem for some of our clients or patients. You know, if a prescription wasn't sent to the pharmacy in time, or somebody was having some real problems, and many of them were self-medicating with opioids to deal with some mental health problems, whatever, they would take it out on our staff, our front desk staff or our other clinical staff. And so we had to spend some time with in our agreements saying, you know, you can't abuse our staff. The patients agreed to random pill counts and drug screens. They said they wouldn't use other illegal substances that would interact adversely with the MAT medication, and that really had to do with not with with marijuana, but with benzos, particularly, which combined with opioids can create some really significant life-threatening respiratory depression. And then people agreed to meet their financial obligations to the practice, and we worked with them on that. So I've got several slides here on the lessons that I learned, and that I'll go through quickly. And no one has all the answers, particularly myself. This is the most humbling thing to be involved with. It's very gratifying, but it's incredibly humbling. And there is no perfect treatment blueprint. Despite all the guidelines that you can find, you have to individualize your therapy for each patient. You have to individualize. Like any chronic disease, you need to listen to people. You need to know how they like to have information communicated to them. You have to know something about what their lifestyle is like, their living situation, their transportation. A lot of the social determinants of health and illness have to be explored, and that is really important. You have to assume polysubstance use. Almost everybody's used more than one substance. Some folks started when they were 9 or 10 years old, doing drugs with parents. They started drinking. They have a history of some kind of abuse, and they were self-medicating. They learned to self-medicate to take care of these things, to take care of their psychic pain as well as their physical pain. Patients don't follow a linear course, so you have to sort of expect that there are going to be some lapses, and we're taught in medical school to fix people. I mean, and people don't get fixed. That's just a myth. And with any chronic disease, things don't follow a linear course. You hope that eventually they're on the way up. Expect people to test too, is one of the things I learned, that people will not just testing me and how I respond to to their behavior, but they test themselves, thinking that, well, I've been doing this long enough. I'm in control of my addictive behavior, and I'm able to handle this. Expect to be conned and manipulated. People who have a substance use disorder, a serious substance use disorder, are survivors, and they have learned to survive by manipulating to get what they need. This is a lifelong disease, and it needs to be treated that way. People don't get fixed. They don't get cured. They go into recovery, and hopefully it's a very strong recovery. Many patients will never be able to discontinue the meds. And when I first started doing this in 2005, my Medicaid patients I was told by Medicaid, you can only treat them for 2 years and then you have to stop, which is just incredibly stupid and self-defeating. Fortunately, they don't tell us that anymore. And a lot of the people I work with in groups say that they don't think they're ever going to come off of it, because, like people on insulin, the insulin is normalizing their blood sugars, and they'll stay on it lifelong. People who are on buprenorphine oftentimes, or methadone, will say, my life is stable. I'm very happy the way things are now, and I'm going to stay on this. I'm never going to come off of it. I don't have any side effects. You need to be flexible with agreement violations, and I talked a little bit about that before, about the marijuana. There are no slam dunk predictors of success or failure. Don't get arrogant about that. Co-occurring illness is the rule, not the exception. So you need to develop a support network of behavioral health people. And as Carol has said before, addiction is a family disease. If you can engage family in this so they understand what's going on, that's and are supportive, that's helpful. I can't tell you how many people that I prescribed buprenorphine for who said to me, my wife or my husband, my mother or father don't want me taking this because it's just another addictive drug. They have to understand the benefits of the medication. Encourage openness and family support. Having a trusted PCP is extremely important, although today it's really hard to find a PCP, and it's hard to develop a trust relationship when you see that person for only 10 minutes. Employment is extremely important, particularly in a recovery-friendly environment. And where I work up here in Lebanon, we have a number of recovery-friendly workplaces, which is just terrific. There are people, they understand that people in good recovery are terrific employees, and people feel free to come to them to talk about what's going on, what stresses there are in their lives. And you want to discourage contact with friends who use. One of the things, I'll get to this. So you need to be flexible about but consistently address certain aspects of the agreement. For example, the behavior and paying bills. If you don't, news travels fast in the street, and people will, it gets around that you're a soft touch, that they don't have to go ahead with agreeing to the things that you say they need to agree to, and they'll get their medication. So be consistent. Your entire office staff needs to be on the same page. And I talked about job, how important employment is. There's this whole housing first initiative right now. If people don't have stable housing, it's extremely hard for them to get into good recovery. And oftentimes they don't have housing and they don't have transportation. So those need to be assessed, and having people in your office who are skilled at making appropriate referrals is an important part of the team. The counseling piece is important, as we mentioned, and I'll tell you, the personal rewards when a single patient stabilizes are enormous. Again, I can't tell you how many times I'm out in the community seeing people who I have worked with who have got their lives back together, and I'll be in a restaurant and a waitress will come by and she'll say to me, it's been 5 years now and I haven't used, and I'm doing so well, and my husband's doing well, and the kids are doing well. I can't thank you enough. Life is good. That is so gratifying. I've done full spectrum family medicine, delivered hundreds of babies, and done all kinds of stuff, and this is as rewarding as anything as I've done. So in summary, there's a need to expand access to evidence-based treatment, particularly medications for opioid use disorder, to increase treatment retention, and to support long-term recovery. And I should add to that, and you need to be part of a team. There are some resources. This is part of New Hampshire Technical Assistance Center, and as you know, because you're here, that it meets virtually every other month, and some great programs as part of this series. If you are a prescriber, if you're not a prescriber, SAMHSA has this treatment improvement protocol, tip 63, which is superb. You get it for free. You just get in touch with SAMHSA, and it's got a lot of really good information in it about the use of medications for opiate use disorder. Tip 63. I think actually you can even get it online if you go to the SAMHSA website. You folks all know about the doorway, I'm sure. Another good resource because it can help you with some referrals. And 211 is the helpline for individuals and loved ones who are affected by substance use disorders. Thank you for your patience.
Thank you, Dr. Mason. And I can say for sure the tip 63 is available online. Way back in my former life, I worked on tip 63 a long time ago and on the update, and on other various SAMHSA publications. So yeah, it's actually easier to download that stuff than to have them ship it to you these days. They still print copies, but then they prefer you pull down a PDF from their website. So little footnote there. All right. Thank you to Carol Furlong and Dr. Mason. Appreciate it. We have about 20 minutes left to open things up for questions. People can unmute and ask questions. I can also pop something in the chat and I will monitor that and relay those questions. I'm going to pause recording so people can feel free to speak as they will, and know that it won't be up on our website later for other folks to potentially view. So I'm pausing now, and
Perfect. Thanks so much, Elliot. So just before we finish, we'd like to thank all of you for being here and encourage you to visit our website, nhtac.org, where you can sign up for future communities of practice, view previous ones, and get involved. And as promised at the start, we'd like to share the presenter's contact information. So as to not have to make a note of what's on the screen, I'm going to pop this in the chat for you, and you can find Carol and Dr. Mason's email addresses and phone numbers to be able to reach out to them. Finally, we would really appreciate your feedback on this COP. Also find out issues that you'd like to be discussed in future COPs. So we're going to post an evaluation link here. If you wouldn't mind taking a minute to fill out that evaluation after this event is finished, we'd be really grateful. So with that, we'd like to thank all of you for joining us today. Thank you, Dr. Mason. Thank you, Carol. Thank you, Elliot. Thank you, all of you, for your participation. And we look forward to seeing you again next time.